before we just get rolling with the semester and it's winter and fall before we know it. Time's flying. Okay. Let's get started. I think I got everyone written down. First and foremost, I wanted to apologize to you guys about the whole quiz situation. Like I said in my email, I'm very, very much human. I posted it on the wrong D2L page, and kids in a completely different class started taking a quiz that they had nothing, like literally nothing, no idea what they were doing. So I apologize to you guys. I hope you saw it, got my email. It's been up and on there. Like I said, this quiz is not going to negatively affect anybody. It was there to give me an assessment of where you guys are at with anatomy, with terms, with certain areas of the body, and any point you got from the quiz will only positively affect you. Again, it will not negatively affect you. It was basically like an extra credit. Okay. Did anyone have any questions from the quiz, particularly like were you confused at all, or any really just kind of stuck on your mind? Okay, good. How about lab? How was everyone's first week of lab? Any complaints, comments? Oh, go ahead, Peter.
Oh, no, I was just saying it was good. It's a good week or day.
Okay, I'm getting some good, some thumbs up. Excellent. And keep in mind, it's all about routine, getting yourself in a routine, getting used to the due dates for things. So when lab is due versus when the homework and the quiz are due, the homework and the quiz are always going to be due in a week. So it's due before your next lab starts. The lab is always going to be due 24 hours after lab is finished. If you have any questions on lab or any of the content, need to stick around a little bit afterwards, that's fine. Just let me know. All right, let's get started. At the end of class today, one of my students from last year, Brianna Montoya, is going to be popping in. She is going to be leading and in charge of the tutoring services strictly for kinesiology. She was an excellent student. She understood the content. She worked very, very hard. She knows the keys to success in this class. So again, she's going to be popping in later to talk about her availability, how you guys can meet with her, et cetera, et cetera. But she's a phenomenal resource, a free, phenomenal resource to have. So take advantage of it. If it's there for you and you guys, after the first few weeks, feel like it's already been really tough and you're struggling, take advantage of having a resource available. Okay, we are going to get started with arthrology today. I do not think we are going to finish this. It's a bit longer of a lecture, but it covers some really important content. Again, a lot of our fundamentals and bases for kinesiology. Give me 1 sec. Okay. Let me know when you guys can see my screen that I'm sharing. You guys can see the presentation, not just PowerPoint itself. Okay. Thank you. Thank you, Sean. Great. Thank you, guys. All right. We are starting with arthrology today, and you guys are going to be beginning this also in lab this week, the skeletal system and arthrology. Does anyone know what the Latin root term arthro actually stands for? A-R-T-H-R-O, arthro. Okay, excellent. Joints. It's actually the study of articulation and joints itself. Very good, Mercedes. So arthrology is what we are going to be getting into. So a joint itself, it's a rigid element of the skeleton, and it's where two bones actually meet together to make movement of the body. A joint is two bones meeting actually at one point. And again, this comes from the Greek root term arthro. So articulations, they could be functional. So that first blank there is going to be functional. We need our joints to be functional if we want to have movement of the body. And that's comprised of cartilage and bone. So we take those two bones, we create cartilage around it or within it. And from there, that is how we're able to get those two bones to move together. Of course, we're going to need the help of our muscles in order to make the movement to actually happen. But without that original skeletal structure, we wouldn't really have anything there. And the structure of our joints, the point of them is to create some sort of resistance to other forces. So any type of crushing force we might have, aka when we are walking or jumping, a crushing force or a compression force is anything that has two components coming together. A tearing force, at our joint, we use our ligaments to help keep them stay close together in order for them to be prevented from coming apart. And then there's other types of forces that we've talked about before. Do you guys remember from last week? Any other type of force? Maybe in lab we went over this as well. What are some other types of forces you might see or have? How about the force that goes like this? It is a shearing force. So we're gonna talk about that more in depth, especially within the next two chapters. But a shearing force is a parallel force. Remember, parallel means they stay alongside of one another. So a shearing force at the joint is going like this when they should technically be just staying stable like that. So joints have different types of classifications. The first one we're going to talk about is a structural classification. The term structural means how are these joints put together? What keeps them together and what allows them to stay together? So that depends on the material that actually binds the bones together. So when I say material, it could be fiber, it could be cartilage, or it's going to be a synovial joint. And it also, the structure itself also depends on if there is a joint cavity present. The term cavity means any type of opening or hole. So a joint cavity is a space dedicated for that joint to fit into. So the three, like I said before, the three types of materials that are predominantly used are going to be fibrous, so different types of fibers. They're usually some sort of dense connective tissue, so they're tough. A form of cartilage. And then lastly, again, synovium or synovial fluid. Now, this is the function. Function is the main way that joints are classified, okay? So structure is kind of a small basis, and you're going to see with each function, the structure goes alongside of it. So the three types of functional classifications we have. The first one is called synarthrosis, or a synarthroidal joint. A synarthroidal joint means no movement. So this type of joint is supposed to stay close and tight together. So there's not a lot of movement here at all. Maybe the slightest vibration. But other than that, a synarthroidal joint is not supposed to be moving. Can anyone think of a synarthrotic joint in our body off the top of your heads?
Carpal.
Did you say carpal, Deshaun?
Yeah.
Why do you think carpal? Let's hear.
Well, I'm saying it from not like the part that you bend, but like from like side to side.
Okay, I get what you're saying there. So you're going to see, we'll show you in a bit why the carpals are not considered a synarthritic. They actually move a little bit more than expected, but I definitely get what you're saying. They're not like your shoulder that moves like this. Oh, sorry. I had one at the top of the chat. Okay, Jared, very good. The plates in our skull, excellent. So a good first example is going to be how our skull bones are put together. We have made up of our skull, we have one bone here, we have two here, one big one back here. So those are put together, they fit very, very tightly knit together from birth via cartilage and fibers. And then as we get older, as we become toddlers, that cartilage actually solidifies. So we'll talk about that more in a minute, but very, very good. The next type of functional classification we have is an amphiarthrosis or amphiarthroidal joint. Amphi or amphi, PH, amphiarthroidal means little or slight movement. So again, synarthrosis means no movement. Amphiarthroidal means slight or little bit of movement. And then the last joint, the last functional classification is a diarthroidal or diarthrosis joint. This is also called a synovial joint. Synovial or diarthroidal joint has a lot of movement. So the diarthroidal joints, when we think of like our shoulder, our elbow, our fingers, those are all freely movable and have a lot of movement. Okay. Sorry, people are trying to join and jump in the class, and I don't know why it's not letting them. Okay, so going back to that first classification, our synarthrosis. I underlined the N in synarthrosis. Think of the N as in no. There should be no movement. Most synarthroidal joints are considered to be fibrous joints. So here we're taking our structural classification. Remember, structure means what it is made out of, and we are now combining it. Sorry, guys. Okay, so it is combining structure, how it's made, aka the fibrous or the fibers, and it's also combining the function. Synarthrosis means no movement. It's a non-moving fibrous joint. Okay, the first type of synoarthroidal joint we have is a suture joint. So Jared mentioned the plates of our skull, aka our skull bones. Those are considered to be suture joints. They are bound together by very, very, very tiny fibers. And they allow the slightest bit of movement, because think about it, our brains are going to grow. Our head is going to grow. As our brain grows, we need those bones to move the slightest bit. And then once they're done growing, the brain and the sutures begin to ossify. So ossification means they harden. So then it hardens into one large skull. How many of you have heard of a soft spot as a baby? Or like a baby having a soft spot? Maybe you felt it before. Okay, Mercedes and Tia, someone in the chat, explain to me, or Evelyn, explain to me, what does a soft spot actually feel like? In your own words and thoughts. If you felt a soft spot on a baby, what does that feel like? It feels like a peach. Mercedes, that's pretty spot on. It feels like a little peach. It's soft in a certain area. And then if everyone feels the top of their head now, it shouldn't feel that gaping soft area like on a peach. It should still, everywhere should feel pretty hard. And that's because our bones ossify together. Once we reach full ossification, that is when we reach synostosis. So S-Y-N-O-S-T-O-S-E-S. Synostosis means full bone ossification. Oops. The next type of joint that is considered to fall under our synoarthroidal joint is a gomphus. The gomphus joint, prime example, is going to be our tooth socket. I'm not just talking about our loose teeth when we're little, falls out, tooth fairy comes. Our gomphus joint goes down into our maxilla and our mandible. It is extremely deep. And again, it's very tight in there. So the gomphus is our tooth socket, and our teeth are connected by, it's called the periodontal ligament. I will type that in the chat for spelling purposes so you know. Periodontal ligament. Any questions on our synoarthroidal joint? Remember, that's no movement. So if you see synoarthroidal, the function is no movement, and the structure is fibrous, tiny fibers. Okay, our next classification is going to be that amphiarthrosis joint. And this is the little or slight movement. Okay, little or slight movement. And the structural classification, is the cartilaginous joint. So there's cartilage that holds the joint in place and keeps things together. Function, slight movement. structure cartilaginous. So partially or slight movement. Now, we have 3 types of joints that fall under this classification. Okay? The first one is a syndesmotic joint or syndesmosis. How many of you have had a high ankle sprain in the past? A diagnosed high ankle sprain? Sean? Okay, very good. Deshaun, tell me about what did your high ankle sprain feel like and how did it happen? Where was your pain located?
So I was going for I was in a basketball game and I was doing the jump ball and I jumped for the ball. I came down and I like twisted and I couldn't I fell to the floor. I couldn't really get up. I had to be carried off.
Wow. Okay. Very good. Where was the pain located for you?
It was mostly located in the anterior side. It like swelled up really fast.
Okay. Excellent. I saw Jared and Courtney also have had high ankle sprains. Can one of you two tell me about where your pain was in the experience?
I will. Mine was kind of like up higher in my ankle, like it wasn't low down where you would expect it.
No, perfect. You're spot on. So high ankle sprains is a sprain at this inferior tibia fibular ligament right here. I don't know if can you guys see my arrow?
Yeah.
Okay. So the inferior tib-fib joint right here, that is not supposed to move a lot. Like I said, it's an amphiarthrodial joint. There's not supposed to be a lot of movement there. If we are spraining, AKA stretching out that ligament, imagine the type of pain we would be feeling. It also is indicative of the tissue in between our tib-fib, the interosseous membrane also gets stretched out. So this is an example of a syndesmotic sprain or a syndesmotic joint. The next type of joint that we have is a symphysis. We see a lot of symphysis joints in between 2 flatter, larger bones. So our first example is going to be our pubic symphysis. If you look down at the bottom here, connecting the 2 pubic bones is our pubic symphysis, and it's a thick piece of cartilage. It is a thick piece of cartilage, kind of almost like a disc shape in between the 2 pubic bones. Now, why do you think we need partial movement in between these 2 bones? Why couldn't our entire pelvic bone be connected and hardened and ossified into one? To give birth, excellent, Jared. To give birth, yes, especially for females. We need those hip bones to expand as a child grows in that uterus area, okay? So we need a little bit of movement there for childbirth. Excellent. The next prime example is going to be where our vertebral disc is located. I'll make sure you guys can see this. So again, our vertebral disc, a rounded piece of fibrous cartilage. Rounded. It's very thick. It's very tough. And our vertebral discs are responsible for shock absorption. So it sits in between those 2 vertebrae, right on top of each other. And then lastly, the last S joint we have is a synchondrosis. Now, I'm going to type this in the chat. Synchondrosis. Okay? An example of a synchondrosis joint is where our rib attaches to our sternum. We get costal cartilage. So costal cartilage is an example of a synchondrosis joint. I put up another example, epiphyseal plate. Who knows what our epiphyseal plate is? Okay, good, Courtney, Jess, both Courtney and Jess. It is our growth plate. It was that we mentioned that last week. Alex said growth plate. It was mentioned, oh, I'm sorry, I did not hear anyone if you spoke. Sorry. It was mentioned last week when we went over our skeletal system and our long bones. That growth plate is located in between the metaphysis and the, so it's part of the metaphysis. It is located in between our diaphysis and the epiphysis. So the epiphysis is the end of the bone. The diaphysis is the long shaft of the bone. And then our epiphyseal or growth plate is located right underneath our epiphysis. All right, last but not least, our diarthrotic or diarthroidal joints, aka our synovial joints. Those are our freely movable joints, okay? These have a ton of motion in this joint because of the structure. Now, synovial joints have a very particular structure that gives them all of this movement, which we're going to talk about in a minute. There are 6 types of diarthroidal joints. So there are 6 different types. And Deshaun, we're going to cover our carpal joints over here. Our carpal joints allow our wrist to move. They work together with the other carpal joints to kind of glide in order to give more movement to the area. And we're going to go through each of these 6 classifications. So we're going to spend more time on our synovial joints than we are with probably the rest of them, because there are so many and it's the ones that we see the most often. Because there's a lot more movement, that means they're also probably going to get injured more since they're not very stable. So the general structure of a synovial joint. Here I have the picture of our 2 bones together, and the whole thing is created into a joint capsule. So the very first one is articular cartilage. So articular cartilage, aka where this blue arrow is, this covers the end of the 2 bones. So articular cartilage is made up of hyaline cartilage. And this covers the ends of the 2 bones so that they can move together freely and basically not impeding on the other one because it has a smooth surface. It also helps absorb compression and different types of compression forces. So the first one is articular cartilage. Our second is going to be a joint cavity. Now, the joint cavity itself is really what makes our synovial joints unique compared to the rest of them. The joint cavity is this entire empty space. When I say empty, meaning there's no actual structure other than fluid. But the joint cavity itself is where the movement is able to take place. Without that joint cavity, the bones would just be stuck like this together, and if they tried to move, they wouldn't be able to. So it needs that space in order for movement to occur. So the first one, again, articular cartilage. The second one is our joint cavity. Okay, the next part of our synovial joint structure is going to be the articular capsule. The articular capsule. So when we think of a capsule, it completely surrounds and encloses an area. Think of a pill, a gel cap pill, like Advil that you take. The capsule is what sits around the actual medicine. So the joint, the articular capsule is what surrounds the joint to keep everything inside of it. On the outside of our capsule, we have dense connective tissue and we have loose connective tissue. The dense connective tissue is supposed to act like a protection. Its structure, it's very, very tight and firm. And then that loose connective tissue is going to be our synovial membrane. So again, articular capsule. Next, we have our synovial fluid. Now, synovial fluid, if you've ever seen it in real life, it's kind of gross looking. It looks like egg whites. Everyone, I'm sure, has seen egg whites before. If not, I'm sure you have cracked an egg and have seen the fluid around the yolk. That's actually very similar to what synovial fluid looks like. It's very, very thick, but it is filled with nutrients. Synovial fluid is filled with nutrients. Glycoproteins, most importantly. Those glycoproteins are what provides nourishment to the inside of that capsule. Without that fluid there, it would be completely dried out and it would not, our joint would not move very well at all. Okay, last but not least, is there a box here? I apologize for interrupting. Is there a yellow box here in like blocking?
Yeah.
Okay, thank you. Give me one sec. Usually if I stop share and go back, it should help. How about now?
It's gone.
Okay, thank you. So I figured. Perfect. All right, now our last structure for the synovial joint is going to be reinforcing ligaments. Reinforcing ligaments. We have two types of reinforcing ligaments. One is extracapsular and the other is intracapsular. Extracapsular means it's on the outside. So for examples of this could be our ACL, our PCL, MCL, LCL. And then we have intracapsular ligaments. So they are located on the inside of the entire capsule. And again, they are reinforcing. So they, as I mentioned, our synovial joints have a lot of movement So we need these reinforcing ligaments to almost help protect it from having too much movement. Too much movement can lead to injury or wear and tear and overuse, and we don't want that. Our synovial joints are filled with a ton of sensory nerves. So sensory nerves, aka sensory receptors, they help detect any type of pain that we might have going on in the joint. It is richly supplied with nerve sites, nerve endings, and also richly supplied with vascular. So a lot of blood supply goes in there. And these sensory receptors, they also monitor how much the capsule's being stretched. Say you're moving your arm all the way back as far as possible, and then once it reaches that end of the range of motion, you begin to feel pain and discomfort. That's because my capsule's not meant to go much further. So it sends a pain signal to the body saying, hey, time to stop. That's as far as you need to go. So it monitors the amount of range of motion by sending nerve signals to the brain telling it stop. Again, synovial joints are also supplied with a ton of arteries, veins, and an overall large blood supply. And as you saw before, our synovial fluid is a filtrate of blood, meaning when you take blood and you put it through a centrifuge, it helps separate different parts of the blood. That's where synovial fluid comes from, and that's what is located inside of that joint. So that also, again, a ton of nourishment, a ton of nutrients, glycoproteins, and of course it helps decrease any friction in the joint. Okay, some of these synovial joints have an articular disc. So articular, remember the term articulate means a joint. So an articular disc is a small round piece of cartilage that sits in between the two bones, and it helps cushion the joint. It helps decrease any type of friction, and it cushions the joint from any damage that the one bone might occur. If you look at the two joints I put up here in the pictures, the ends of the joints, they're pretty rough and they have different shapes. So without that cushion there, that bone is going to do a little bit of damage when it starts to move. So we need that piece of cartilage in between to help cushion the area. Can anyone think of another body part that has a type of articular disc located there? Articular disc, let's see. Okay, very good, Lexi. The meniscus, oh, from Alex. Great job, Alex. The meniscus in our knee, excellent. Our meniscus is a round piece of fibrocartilage that sits on top of the tibia. It sits there so then the femur can come down and create motion. Excellent. And again, it adds that cushion and shock absorption for the area. Very good. All right. Now, how do synovial joints function? So the first one is going to be the articular surface. The articular surface creates a major role in joint stability. So depending on the surface of the two bones is going to determine how stable the joint is. For example, if one end of the bone is rounded at the bottom, the other bone surface is shaped more like a U. That means this end can fit into this end. And that makes the joint very stable because it fits nice and snug in there. If you have one surface of the bone shaped like the U, another surface of the bone shaped like a U, but it's turned, then they connect like this and they lock into place. They can move like this, like this. So the articular surface plays a major role in joint stability. The next functional aspect to a synovial joint is going to be our ligaments. The more ligaments in a joint, the stronger it is. Who remembers what are the two main jobs of a ligament? The two main jobs. Let's see, we got one. Okay, yes, stability. Let's get a little more specific. So a ligament connects bone to bone, right? Ligaments connect bone to bone. Tendons connect muscle to bone. So the ligament's first job is going to be simple connection, holds the two together. The next job is to let's see. Okay, yes, joint support, absolutely. It supports the joint by allowing or not allowing excess motion. So our ligaments, if they're connecting, let's say we have a ligament connecting bone to bone here, one bone, second bone. There's a ligament holding these two in place. If this bottom bone tries to move forward, there's going to be a ligament that's going to end up stopping it from moving too far. So ligaments also prevent excess motion, which ultimately allows for more support and makes it more stable. Very good. And then lastly, muscle tone. Muscle tone is the most important factor in joint stability. We need muscle tone in order for our joints to be protected. It is a dynamic form of protection as well. When we are walking, playing sports, our muscles is going to be the first, second, and third line of defense before we reach our ligaments. So if our muscle fails us from protecting that joint, next we have ligaments. So that's why if anyone's ever torn ACL before, normally ACL tears occur from either contact or no contact. For non-contact tears, we're usually planting one part of the body, so it's getting stuck in one area, usually the ground, and then the rest of the body is going to move in a certain direction. We rely on our muscles to help kind of stabilize us and keep us in place, or else the joints are just going to move around as well. So muscle tone was the last one. Okay. Very, very important. Emerson's law. I want you guys to drill this into your brain. Emerson's law is a very important concept. I need you guys to remember and understand. So for everything given, something is taken. In the world of kinesiology, athletics, and movement, we are always going to be fighting a battle of mobility versus stability. So mobility versus stability. There is an inverse relationship between mobility and stability. Who remembers what does inverse stand for? inverse relationship? Anyone? Okay, very good. Opposite. Yes. An inverse relationship means an opposite relationship. So for example, Emerson's law, for example, mobility versus stability. My shoulder, our shoulder joint has a ton of mobility here. But the more mobility I have, the less stable it is. The less stable a joint is, the more likely it is to get injured. So it's great that it has all this motion. I'm able to do things, move, etc. However, I lose stability because I am more mobile. And then there's the opposite, the more stable a joint is. So for another example, our ankle joint. Our ankle joint has movement, obviously, but it's not as much as our shoulder. Our ankle has to be very stable. Think about it. All of the weight of our body comes down to our ankles and our feet. So we need that stability there. And when we become too mobile, aka hypermobile, that's when we start seeing a lot of ankle injuries. We sprain our ankles very easily. Okay, so Lexa said she had no stability in her ankle, but all mobility, and now it's the Lexi, what do you mean?
I had surgery. I tore all the ligaments in my ankle, so I had no stability at all. My foot would move in all directions, and then I had surgery, and now it's the opposite because I have synthetic ligaments.
Yep. Got all new ligaments in there. Tighten that bad boy up. Exactly. So that's.
So I have no motion at all.
Right. That's rough. But that's exactly the sacrifice we kind of give. It's one or the other. We ultimately want to try and find a balance between the two. That's usually our goal. We'll do yoga in order to stay mobile, but then we'll lift weights and do strengthening exercises to stay stable as well. So we're trying to find an ultimate balance. So that is Emerson's law. Everything given is something taken. All right. Now we're going to move on to our 6 classifications of diarthroidal joints. Remember, diarthroidal means what? How much movement is there? What did we just learn? Okay, Cassiana, very good. Mercedes, very good. Freely movable. Our diarthroidal joints are freely movable, which, again, they're also called synovial joints. So the structure that we just went through, the structure of our synovial joints, that is what we're going to see on all 6 of these classifications. They have this type of structure. So the first one, Deshaun, I believe our first one is going to be our carpal joints, aka our plane joints. Our plane joints are gliding. They slide and glide. They are ultimately 2 flat surfaces that slide and glide on one another. Okay? The purpose of them is to help give movement elsewhere in the body. Now, because our plane joints, since they don't move like this, they don't move like this, none of that. They do not move on an axis. I know in lab last week, you guys went through the axes, and we're going to go through that again today, if we get there. Our plane joints do not move on an axis since they don't do any of this. They simply slide and glide. So they don't need a sagittal axis. They don't need a frontal axis to move on, since they only slide and glide. So they are considered to be non-axial joints. Again, examples are our carpal bones and our tarsal bones. So the joints between those two bones, or between the carpals and between the tarsals. Those are examples of plane joints. All right, the next one are good old pivot joints. I don't know if anyone's ever seen Friends before, the episode when they're moving the couch and they do the whole pivot scenario. When we pivot, it is a rotational movement. It is a rotational movement. So in Friends, they were trying to pivot the couch outside of the door. It was a whole mess. Highly suggested if you haven't seen it. So a pivot joint only moves on one axis. It only rotates. Okay? It does not move like this. It does not move like this. Pivot joints only rotate. Who remembers from lab? Who remembers that one axis that comes down from the top and goes straight down to the bottom? What is the name of that? Okay, Mercedes, very good. It is a vertical axis. A vertical axis comes down from the top, goes straight down that way. So the movement that occurs around that axis is rotation. Since pivot joints only have that one rotational movement, it is considered uniaxial, meaning one axis. So the examples, two joint examples, C1 vertebrae sitting on C2. So C1 sits on C2 at our neck and allows rotation. Another example in the body is our radio-ulnar joint. Our radio-ulnar joint is located radio, so our radius meets our ulna up here. At this joint, rotation occurs. That's what allows pronation and supination at our radio-ulnar joint. So if everyone sticks their arm out, if you put two fingers, your hand, whatever, over, so here's the crease in my elbow right here. I want you to put your fingers below that crease. Hold that area. And I want you to pronate and supinate. So that is a rotational movement at this joint. Again, that is one axis. Now I want you guys to think, out of the three axes you learned in lab, vertical, sagittal, and frontal, which axis does the rotational radio-ulnar movement occur on? This is a tough, let's see. Kiara, I like where your head's at. It is not. Now, we talked about anatomical position last week. Anatomical position is where we always reference the body from. So I'm going to stand up. Okay, Jared, excellent. If I'm in anatomical position like this, here we have a vertical axis coming all the way down. So that rotation is occurring, is rotating around this axis. Very good. That one's tricky. It's a little confusing to kind of picture in our heads, but it is a vertical axis in the transverse plane. All right, next we have hinge joints. A hinge, just like on a door, moves on one axis. That is where we are able to do flexion and extension. Flexion, extension. Oh. I want everyone to look at something real quick. I put talocrural joint, aka knee. That is not the knee. I need to change that ASAP. The talocrural joint is our ankle. And we do dorsiflexion and plantar flexion there. So it is still extension and flexion. Just know that is the ankle, not the knee. Okay, so again, hinge joint, uniaxial. That is where flexion and extension occurs. Let's look at this picture real quick. I actually really like it. So if you take a look, I'm going to use the highlighter right here. This is the head of our radius right here, this rounded segment. This is what rotates on the ulna here. So when we pronate and supinate, the head of the radius is rotating on the ulna right here. So that's how that pivot joint works. It's rotating. Now, if we look at our humeral ulnar joint, aka the humerus and the ulna, so here, I'm gonna change colors. So here we have the humerus, here we have the ulna. The two of them, that is where flexion, and extension occur. Flexion and extension. It is a hinge joint like the door. Okay, now moving on to our condyloid joint. Condyloid. Example, our radiocarpal joint. Our radial, so this is our radius, and it meets our carpal bones. Radiocarpal. What movements are we able to do at our wrist? Someone tell me, what movements are we able to perform at our wrist? Okay, very good. We are able to go do extension. How about this motion? What is that one? Okay, flexion, very good. How about this motion? Ulnar deviation. So here's my ulna. Ulnar deviation means my hand and wrist moves towards the ulna. How about this way? What bone is this? That's our radius. So if this is ulnar deviation, this has to be radial deviation. Very good, Jared. So I'm able to do movements here and movements here. If I have movements in two different planes with two different axes, that makes this joint biaxial, since it has two different axes and two different planes of motion. For flexion and extension, which axis do we have for flexion and extension? Which axis is this? Not transverse. Frontal. Cassiana, thank you. Frontal. Okay. So I have a frontal axis, and the movement occurs in which plane? Flexion and extension occurs in which plane? Frontal axis, sagittal plane. Excellent. We get movement in the sagittal plane. Remember, the sagittal plane cuts the body straight down the middle. So movements occur in this plane with a frontal axis. Very good. Now, ulnar and radial deviation. This occurs in the opposite, the frontal plane with the sagittal axis. So remember just like a windmill, there's something going straight through the center of the windmill and it rotates around that center. So ulnar and radial deviation have a sagittal axis in the frontal plane. So that's what makes that joint biaxial. And then the second example for our joint is the metacarpal phalangeal. So our metacarpal phalangeal, we have our metacarpals here. So starting from down here, coming up, where it meets our phalanges. That is the metacarpal phalangeal joint. So basically where our knuckles are. So at this joint, we are able to do abduction and adduction, also flexion and extension. So that's what makes our metacarpal phalangeal a condyloid, because we have biaxial movements here as well. Just the picture. Sometimes you will see that a condyloid joint is also called an ellipsoidal joint. So an ellipsoid or ellipsoidal. Either term works perfectly fine. All right, where are we on time? Okay, I'm going to finish up the last two. So our next joint is a saddle joint. Now, I want you guys to take a look at the two articular surfaces that make up a saddle joint. So notice it comes up and it has this hollow section on top. But then if you look at the bottom surface here, it does the exact same thing. These two surfaces have the exact same shape surface. The only difference is, so they start out like this. Now with a saddle joint, all we are doing is changing the direction and they fit in like this. So it is the same shape surface. We are changing the direction. So one is basically going to turn and then it's going to fit in with the bottom. So if I turn it upside down, they are the exact same. Once again, the surface shape does not change. So that's what makes a saddle joint. I don't know if anyone does ride horses and actually has seen what a saddle looks like. It comes up on two sides and down on two sides. And the carpo-metacarpal joints are an example of a saddle joint. So carpo-metacarpal. Tell me, someone give me an example. Give me the two bones that come together to make up our carpo-metacarpal joints. The two bones that make up the carpo-metacarpal joint. Anyone? So our carpals here, the tiny carpal bones that we were talking about, and our metacarpals. So the joint is located down here. And at this joint is where we're able to do flexion and extension. And then there's very, very minimal abduction and adduction, which again, since that is two different movements on two different planes and axes, that makes it biaxial. The most important thing about our saddle joint is knowing the two surface areas of the bones are the same. So two separate bones, same surface area. One is just rotating to fit in with the other. Just giving you an idea of what they kind of look like. And then last but not least, our most movable of our diarthroidal joints of the 6 classifications is going to be our ball and socket joint. Our ball and socket joint has the most movement and motion because it moves in 3 different axes on 3 different planes. So 2 prime ball and socket joint examples. Our ischiofemoral joint. Who knows? What is our ischiofemoral joint? What's the common term for this joint? Not the animal.
Hip.
Hip. It is our hip. Excellent. The ischiofemoral is our hip joint. And then our glenohumeral is where? What is our shoulder? Excellent. Our glenohumeral joint is our shoulder. Very good. Ball and sockets, 3 different axes. So we have our sagittal axis, which again allows for our sagittal axis goes this way and it moves in the frontal plane. So at our shoulder, we're able to do abduction, and adduction. Next, we have flexion and extension. So that's a frontal axis. Remember, coming in from the side. Frontal axis in the sagittal plane. Internal and external rotation. Now, internal and external rotation can be a little tricky only because we are able to perform internal and external rotation in different planes. So if we go like this, here our shoulders at 90 degrees, our elbow is bent at 90 degrees. I'm able to go into internal rotation and external rotation. In this plane, what axes is allowing for internal and external rotation? which axis comes in from the side? Remember we said this particular axis goes in one side and out the other. Which axis was that? So that was the frontal axis. So the movement is occurring in the sagittal plane. Frontal axis in the sagittal plane. Then we are able to do internal and external. So I'm going to stand up. I want you to look at my arm. Here's my hand. Almost like doing supination and pronation. I'm able to do internal rotation and external rotation. Which axis comes in from the top and goes down to the bottom? Okay, very good. Vertical axis. I'm able to do internal and external rotation with a vertical axis in the transverse plane. Excellent. All right, we are almost out of time. So we have now Brianna Montoyo in here. Well, as I mentioned earlier, Brianna is going to be helping out this semester, and she was my student last year. She did a phenomenal job in my class, and I'm excited to have her help you guys out. So Brianna, take it away.
Thank you, Dr. Arnold. Professor Arnold, sorry, not doctor.
I appreciate that.
Yeah, I always forget which one you are. So hi guys, I'm Bree. I am a junior athletic training major. This is my first year tutoring, so I'm really excited to get started with you all. So just jumping in, everything I say will be posted on the newsfeed as well if you can't keep up or remember. So my office hours are going to be Monday and Wednesday 2 to 4:30. And then Thursday 12 to 4:30. I am an individual tutor, so you do have to set up an appointment with me. But on Thursdays, I'm required to have an hour of walk-in. So from 1 to 2, you guys could just walk in, pop into my Zoom, and you just ask me any question you want. If these hours don't work, I can set up something different. This is just what works for me because, you know, I have to get schoolwork done as well, but I can always work something out with you guys. And tutoring doesn't start till next week, but if you guys, it doesn't officially start till next week, but if you guys need help this week, I don't mind helping at all. But yeah, that's it. You guys have a great professor, and she's awesome. And it's a great course. It's one of my favorites. I'm really happy to be tutoring it.
Wow, that was super nice. Thank you, Bree. I appreciate you. I'm very, very grateful to have you, and I'm sure everyone else is. Now that I have your information, I'm going to post all the tutoring information up on D2L on the homepage for you guys. I'll put your email as well, Bree, and the hours and everything. So again, take advantage of this phenomenal resource. She's here to help. She's not doing it just for fun. I mean, maybe it is fun for you, but she wants to help you guys get better and help you guys understand, again, this very, very important and fundamental class. But all right, we are out of time. So thank you all. Work on these planes, axes, and different joints and joint classifications. Have a great week of lab, and I will see you all, and we will continue with this on Thursday. Take care, guys.
Have a good one.
Bye.